and comment on the YouTube channel. So today I want to begin another series, Neuro ophthalmic examinations. In other words, we want to look at what are those tidbits, what are those salient points, what are those vital indicators every time we are looking at neuro ophthalmic cases. The next class where I'll be talking about the different structures and then how they affect the eyes. But today we want to focus on the precursors. So quickly, you can grab your coffee or your tea or your camo, whatever you take, and then let's go on this journey. Introduction, cases, the neurological systems and neurological disorders and how they affect the eyes, and also what the eyes tells us system. So what were the basics of this field, even if it's beyond their scope of practice, since they are usually the first contact point of contact. The optometrist is usually the first, because the primary eye care practitioner usually the first contact point. So it's important that we have a grasp on this aspect of optometry and then be able to deliver effectively. So neurooptometry is concerned with evaluation, rehabilitation, and therapy, but evaluation in this series, because you cannot rehabilitate what you have effectively evaluated, and you cannot give a good therapy if you don't know how, if you've not been able to localize whatever you are dealing with. So 90% of clinical neuroophthalmic cases is in the taking of listening, specific questioning, and careful evaluation of the information gained in order to form the foundation of a diagnosis. So most times what you are doing is that you are paying keen attention to listen, because most neuroophthalmic cases are hydra-headed, they are complicated, they are dexterous. So we want to pay so much attention listening to what the patient is saying, asking specific questions. Now, a question can unlock and open up several things. Just one question of when did this issue start? That question alone can solve maybe 80% of whatever it is we are even struggling with. So it is composed of attentive listening, taking of notes, specific questions, and careful examination, because there are 1001 examinations we can do, but from the case history it will tell us what we should do, what and what we should not do. Are we together? So this, for instance, maybe we want to check the visual acuity of a patient. We have no business dilating the patient first, because dilation is going to, this is why this aspect is so important, and then of our diagnosis. So the doctor should, from history taking, attempt to classify disorders into three groups. So there are basically three groups we are looking at in the neuro-ophthalmic clinic. The first is the afferent disorders, so that is a group. The second is the efferent disorders, and the third are the headaches and abnormal facial sensations. So when we look at afferent disorders, we are trying to look at pathologies affecting the pathway from the organ, which is the eyes, to the brain. So afferent is from the eye, from the organ to the brain. So we want to look at, and that is where the visual pathway will come in. We want to look at, are there lesions in the pathway? It could be the retina, the optic nerve, the tract, the chiasma, the whatever it is. It could be any of these. So afferent pathways are important, and we should be able to categorize pathologies or cases we see as neuroophthalmic cases into these three categories: afferent, efferent, and then headache and abnormal facial sensations. So also the second kind to the eyes, there are pathologies that are more we see in that aspect. So we want to also be able to isolate this case we are seeing. Is it an afferent disorder? Is it an efferent disorder? Or is it a headache issue? And then headache is a whole ball game on its own, according to the Headache Society. So this is why we must be able to identify these pathologies into these three groups. Now, doing this helps to isolate what we are doing. Doing this helps you to channel your resources to be able to pinpoint what the culprit is. The next point we have to note is that the patient details, such as the age, gender, the race, are subtle yet important points that can help quickly unravel dilemmas and also differentiate similar conditions. For instance, a patient who his job will require him climbing a staircase, maybe 4, 5, 6 story buildings every day, and then he tells that every time he's climbing the staircase, he finds it, he begins to have double vision climbing the staircase. It tells you something as a neuro-ophthalmic clinician. A muscle is being called to play. Are we together? So the patient's age is very important. There are some diseases that are associated to certain ages, certain age. Some diseases are more prevalent. Some diseases are more prevalent in a particular race or in a particular systemic condition or occupation. So this is why it is important that we note all this and then know how to take it up from there. So the first thing we are going to be looking at is case history. Now, in case history, we want to systematically know what we are doing and know why we are doing what we are doing. Now, it is important that the previous records of the patient's care should be reviewed prior to beginning of the interview. Now, we do this so that we can be able to checkmate what has been done, what was not done, and what should be done now and what should not be done now. So a previous record has a way of helping us to compare what we have done before and know if there's an improvement or it is getting worse, because you can't actually tell if a case is getting worse if there is nothing to compare it with. If there is no landmark or no yardstick to say, okay, last 2 years the vision was 6.6, now it is 6.12. Now, in view of this, we can say, okay, it is getting worse. But if we do not have a record of what happened before, we can't really tell the extent of damage with what we are saying now. But then there are cases whereby we might not have the previous record of the patient. It is still fine. But all I'm saying is that a previous record gives you an added advantage. Now, if the patient consents, it is important to involve those who have come to the visit, such as the patient's spouse or close relative, because they can provide useful information that the patient does not know or cannot remember. So most times you'll be seeing cases of probably dementia where the patient can't remember certain things. So you will need the assistance of who they came with to fill up the gap. For instance, a patient can tell you that, oh, my double vision started a week ago, but then it started 2 years ago. But because probably they have dementia or they have some cognitive issues, they cannot be able to give you a detailed information. This is why we want to also, if the patient consent, like I said earlier, to make sure that we also hear from those close to them, who live with them and who see them carry out their daily activities. It is also a silent point. And then these patients sometimes they are nervous, and it's important that the doctor calms the atmosphere by quickly discussing on an area of interest of the patient without necessarily sharing his own view on that matter before case history begins. So most in a neuro-ophthalmic clinic, you find out that the patient are tensed up, the patient are frightened, probably they've been to several clinics, they've seen several doctors, and they've not been able to pinpoint what the issue is. So once they come to you, they are fidgeting, and a patient who is fidgeting might not give you the best of response. So you want to calm them down, you want to let them know that, oh, they are in safe hands, that they are dealing with a professional, and that their case will be solved. So probably discuss in an area of interest. It could be politics, it could be football, it could be music, it could be fashion, whatever it is that the patient is comfortable with, without necessarily you giving so much opinion. Are we together? So, but anyhow or any way you can try to ease the atmosphere to make it a conversational one, not a question and answer, a fire question and answer session. It is also very important that this is done to help ease the atmosphere, and by so doing you find out that the patient is now at ease and can cooperate with whatever you're doing. So case history in children is taken from one or both parents and should be brief yet concise, because children might not be able to give you detail of whatever that is going on, even though we want to hear from them, but we also want to hear from both parents or one of the parents, so that we can have a detailed information of what is going on. And an experienced and knowledgeable clinician often can diagnose from the history, while the novice is usually overwhelmed by the array of information gathered, hence not able to connect the dots. So the more you handle neuro-ophthalmic cases, the more you begin to see that with just a statement, you can even form a diagnosis from just a statement. That from just a statement, you can be able to pinpoint what you are dealing with. So this is why the more you are exposed to it, the better you become. We are all growing in this profession, and one of the things I love about medical practice is that it is a vast well of ocean. It's a vast area of knowledge that you keep learning every day, as long as you are hungry and then you are humble enough to learn from those around you, whether above or below you, or even your contemporaries. So once you can pinpoint these little points, it helps you to connect the dots so quickly. It is important that after the examination is completed, the clinician summarizes the findings in terms that the patient can understand, with necessary referrals and follow-up care in relation to the patient's chief complaint. So we want to always address the chief complaints. So the patient should not come for probably double vision, and then at the end of the day we are talking about maybe glasses, or unless the glasses is going to solve the double vision, or the patient came with maybe a deviated eye, and then we are talking about something else. So we must tell them that at the end of the day, whatever we are doing, we're able to achieve or meet up with the patient's chief complaints. So what are the landmarks in case history? The first is the chief complaint, the age, the gender, history of present illness, detailing the problem, temporal profile of symptoms, and associated symptoms. So these are very, very important, and they should be noted. So let us, and again, the past neurologic and ophthalmic history, the past medical and surgical history, review of systems, family history, social history, and then a brief summary. So let's look at chief complaints and then see what it has in stock for us. So the chief complaint is the primary reason for a medical encounter. It is the reason why the patient came to see the doctor. So if the patient just came to say hi, it is a chief complaint. Are we together? So chief complaint is the primary reason for a medical session. So elaboration of the chief complaint using FODA-Q, that is the frequency, the onset, location, duration, associated factors, relief, and quality. So this acronym FODA-Q, it helps to give us a proper what we are dealing with. So we want to know how frequent. For instance, if the patient says he's having headaches, for instance, and then the headache wants to ask, how frequent does this headache occur? The frequency tells us a lot on the type of headache we are dealing with. When did this headache begin? The patient might say, oh, it began 2 days ago, it began 3 days ago, or it began a week ago, a month ago. The next is location. Where are you feeling this headache? Is it just one part of the head, or is it everywhere, or is it your forehead? So this is also important. Duration. How long does this headache last? And again, does it come with associated factors like vomiting, like tiredness, like auras? These are also important. And then what relieves your symptom? For instance, a patient who has migraine, for instance, migraine headache, will likely tell you that when they sleep, it relieves their headache, or when they are in a quiet room or in a dark room, it relieves their headache. And then the quality, on a scale of 1 to 10, how well will you grade this headache? This is why FODA-Q is very, very important in chief complaints as regarding neuro-ophthalmics. And again, congenital neuro-ophthalmic problems such as optic nerve hypoplasia, cuts, are more likely to be seen in children. So there are particular conditions we are likely to see more in children, like I've listed them on, and they are not that we can't see them in adults, but they are more predominantly in children. Degenerative and vascular disorders are seen in adults more, so you tend to see more of this in adults, and then you tend to see neoplasms occur at all ages, even though the tumor types are more age dependent. So we are likely going to see neoplasms in all age grades. So the common cause of chiasmal compression in children are optic pathway tumors and craniopharyngioma, while in adults are pituitary adenomas. Eye complications of brain cancer, optic neuritis, giant cell arthritis, and advanced retraction syndrome are more seen in women. So this is why the gender of the patient is important. So you tend to see these cases more in a certain gender. And also the chief complaint should be reduced to a sentence containing the patient's age, gender, and complaint. E.g., the patient is a 56-year-old man with right facial pain. So it is comprehensive, it is brief, it is concise, and yet it is detailed. Let's look at detailing the problem. Remember I said earlier that every time we see a case in the clinic, we want to categorize it into afferent, efferent, or headaches and facial pain. So let us look at afferent dysfunctions. So complex of vision loss, its pattern and degree should be explored to help localize proper pathway. So if we are looking at vision loss, we want to know what is the pattern of this vision loss, and also we want to localize where is this vision loss going on, where exactly is it. It could be in the retina, it could be in the optic nerve, it could be in the pathway. So we want to be able to localize this vision loss and then be able to take it off from there. Also, the patient should be asked whether the right, left eye, or both are involved. Sometimes some cases might involve just one eye, sometimes it might involve both, or sometimes it's more in one eye than the other. So we want to also note what is going on, and then the patient should be asked if the visual loss affects the nasal, the temporal, superior, or inferior field of vision. So there are vision loss that affects just a particular field of vision. So we want to know where it is because it gives us an important clue on what is going on. Also, vision loss should be categorized according to its quality and degree, such as complete blindness, grayness, or visual distortion. So if the patient is saying I can't see could be I'm not seeing at all. I can't see could also mean I'm seeing but it is not sharp, or I'm seeing but it is distorted. So whatever it is, we want to grade it. And also defects in color perception should be noted. Most times in a neuro-ophthalmic clinic, we will always do a color vision test. It is almost a must that we have to do a color vision test because it tells us a whole lot about what is going on in the visual system. Now, when complaints are vague, coupled with history of dementia, stroke, or behavioral changes, and no clear ocular explanation for the visual impairment, higher cortical visual dysfunction should be considered. So when the patient is not coherent in what he's saying, or is vague, or he's mixing up things, he's forgetting one or two things, things are not adding up, we should begin to question. Probably it could be a higher visual cortex problem. So let's look at the efferent dysfunctions. Ensure you subscribe, ensure you like, ensure you comment on this channel. Also drop your questions on the comment box. I'm going to check them after now and reply to them accordingly. So the most common efferent neuro-ophthalmic complaint is diplopia. This is the most common one we'll see. Double vision. I want to know this double vision, is it on upward gaze or downward gaze or temporal gaze or nasal gaze? So we want to note this color vision, diplopia. And also diplopia patients should be asked whether the vision is binocular, whether it is horizontal, whether it is vertical, or it is worse in one eye, or is it worse in downward gaze. Whatever it is, we want to know where it is happening. And also neurologic diplopia is almost always binocular, and the defective nerve or muscle according to the direction in which the double vision is worse. So the direction where the double vision is worse is likely where the nerve or the muscle is lacking. Blurred vision is commonly associated with refractive errors, media opacity, and afferent dysfunction, but I can also mask as diplopia. Sometimes what the patient is calling diplopia might not necessarily be diplopia. It could be a blurry vision. So it is important we differentiate blurry vision from diplopia. It is very important. And diplopia masking as a blurry vision can be suspected when blurry vision improves when either eye is occluded. So if we are seeing a blurry vision, but then we don't know if this is actually a blurry vision or a diplopia. If it is a double vision we are dealing with, most times it becomes the vision improves when you occlude one eye. But if it is a blurry vision issue, even if you occlude one eye, it will still be how it is. But in diplopia issues, once one eye is covered, the vision improves. Now let us look at chronicity. Now, an instance of when the symptom first occurred should be established. Optic neuritis usually resolves within several weeks or months. Presence of visual loss for years can be attributed to slowly growing meningioma. Long-standing intermittent double visions could be due to slowly expanding neoplasm or decompensated congenital strabismus. Old photographs of patients are helpful in determining the chronicity of ptosis, pupillary abnormalities, and ocular misalignment. So it is important that we note how chronic is this case. Is it mild, moderate, or severe? So this is very, very important. So for instance, like we said now, that optic neuritis will usually resolve within weeks or months. So if it resolves within weeks or months, you know that you are dealing with optic neuritis and so on and so forth. And again, the rapidity of onset, it is also important. Sudden onset of symptoms suggests vascular processes such as stroke. So vascular lesions that are vascular oriented usually happen suddenly. Most time they won't give you a sign, they just happen suddenly. Are we together? Then inflammatory and infectious disorders may be acute and may last from minutes to days. So when we are looking at inflammatory disorders or infections, they usually start for minutes and it can even last to days. So it is important to know if we are dealing with a vascular issue or an infection issue. Also, degenerative and compressive processes are usually insidious, which means they appear as they are not so serious, but they are very serious, and the patient may not be able to pinpoint the exact origin of the problem and last from hours to months, if not years. Example of a degenerative condition is glaucoma. So it is called the silent thief of the eyesight. So it is just there, and then after a while you find out that it is degenerating, it is getting worse. So this is why we call them insidious cases. Also, vascular or traumatic cases are considered hyperacute and last from seconds to minutes. So cases that are vascular oriented or traumatic oriented, they might last for few seconds to minutes. Also, elevated intracranial pressure can last from minutes to hours. So when we have an elevated intracranial pressure, the patient can experience it for a few minutes to few hours. Also, the pattern of symptoms. This is very, very important. Progressive symptoms suggest comprehensive mass lesions. So when the symptom is progressing, like it is getting worse over time, we are dealing with a compressive mass lesion, a lesion that is compressing the structures around. Also, vascular or inflammatory processes are usually acute and plateau or improve with time. So in vascular or inflammatory cases, you see that it starts gradually and it is as if it is at this peak and it is worse, and after a while it begins to decrease in intensity gradually. That's how we are able to isolate vascular or inflammatory cases. And again, episodic visual loss could be due to migraine, carotid diseases, or seizures. So I'm going to be dedicating a whole segment on migraine, because migraine is under headaches, and it's important we also teach on it. So episodic visual loss could be due to migraine. So there's a migraine called migraine with aura and migraine without aura. In migraine with aura, you see that sometimes there is visual loss, but for a while, and then that is what we call episodic vision loss. And also fluctuating ptosis or double vision that is worse in the evening is highly suggestive of myasthenia gravis. So I'll be talking on ptosis, but it is important that, let me just chip this in, that every time you see ptosis, make sure you look at the surrounding structures. Neurologic diseases such as migraines, strokes, transient ischemic attacks, head injuries, seizures, or prior neuroimaging should be questioned. So when we see migraine, strokes, neuroimaging, we want to question why. And also past ophthalmic problems such as previous correction, cataracts, glaucoma, strabismus, amblyopia, eye patching, or surgery should be investigated. So we want to know